And so, good afternoon again for those of you who are in the East Coast, the Central Time, and good morning to our dear friends who are in Mountain and Pacific. And those of you who are watching this at a later time, welcome. And we're so glad that you are here for lunch with Aging While Black. Uh, I always start by saying that Aging While Black is a multifaceted platform that elevates the voices of Black elders by amplifying their stories, perspectives, and realities. Our goal is to generate collective learning and collective action around the systemic inequities faced by aging Black people and to co create policy and people driven responses for better lives. And I am always excited to get to this moment because I get to share time with wonderful people who are doing amazing things across this country. And that is certainly true today. And I'm excited to welcome Dr. Maurice Scott to Lunch with Aging While Black. Greetings, Dr. Scott.
Thank you very much. Glad to be here.
I am so thankful for this opportunity. I've enjoyed getting to know you over the last 6, 8 months and have just become an admirer of the important work that you're actually doing. But as importantly, the thought leadership that you are part of advancing that I think is critical to Black aging in this country. Over the last few days, we've, by virtue of promoting this, shared a bit about you and your work. But how would you introduce yourself to this community?
Sure. Well, good morning and good afternoon to those in your various time zones. As Raymond said, my name is Maurice Scott. I do go by Scotty. I am a palliative care physician at the University of Colorado School of Medicine. I am from Denver originally, which is ultimately why I came back here. But I did fellowship in hospice and palliative care in Chicago and spent a lot of time doing home hospice visits all over the city, but predominantly on the south and west side of town. And predominantly Black communities. And that's really where the field of palliative medicine became a calling for me, and one in which I just want to help folks live as best as they can for as long as they can, kind of within the constraints of what healthcare can provide and what medicine can provide. But that can only be done through honest conversations.
So, and we're going to explore that more in just a moment, and I certainly appreciate the framing. But the question that I start all of these conversations with after the introduction is what does the concept of aging while Black bring to mind for you?
Well, I think from my lens and my perspective, the concept of aging while Black is one in having to recognize kind of the systemic structures and the systemic inequities that have been going on for generations, and how will those affect folks' access to different services as they age? How will that affect caregiving and ability to stay at home versus going to a nursing home, or those kind of things? And I think certainly generalizing, but I think that the outcomes and the endpoints in the Black community are vastly different than those whose communities have higher socioeconomic income or resources as a whole.
Thank you so much for that. I think it is Laura Carstensen at Stanford, along with others, uh, did some research and advanced this theory in aging that says that both advantage and disadvantage are cumulative over time.
Hmm.
And so certainly one of the realities of Black and Brown communities in America is that there is historically a greater degree of disadvantage.
Mhm.
And if that happens over life, then it certainly is reasonable to think that it would show up in aging. Uh,
Absolutely.
what is palliative care?
So, how I describe palliative care, this is my spiel I use most often, is we're a dedicated group of doctors, nurse practitioners, chaplains, social workers that focus only on quality of life and try to make today in this moment the best it can be for folks. We are a specialty care team that works with, folks like cancer doctors or heart doctors, infectious disease doctors, as they're treating those illnesses. We want to come alongside the patients and their families and make sure that any pain gets well controlled, nausea, vomiting, so that, folks feel well enough to do what they like to do when they're out of the hospital. And then we try to get to know who people are as people outside of what's going on medically. There's so much to each of us, spiritually, psychosocially, what's going on in the community, and bring that into the conversation so that we know what the patient is hoping to get back to once they're feeling better. And then we can have realistic and honest conversations about medical treatment plans that may get them there. So sometimes we do have to have conversations about hopes that they have that medicine will not get them there. And that then is where, we either frame or help reframe and pivot towards pure comfort care through hospice services.
Thank you so much for that. What is interesting, and I thought about it, Scotty, as we were preparing for this conversation, is that while you have been deeply rooted in palliative care professionally and as a passion, uh, much of our conversations have been about advanced care planning.
Mhm.
And so help me and those who are watching and will watch, help us understand how a palliative care physician becomes so ingrained in conversations about care planning.
Around advanced care planning? That's a very good question. So, palliative care at its finest will help guide patients towards treatment plans or treatment options framed purely around the patient's own values. And, kind of with that, or as a result of that, we get into a lot of conversations around, are there red lines in the sand? Are there hard stops for patients when they're coming into the hospital where they say, I'll do all the treatments, but I never want a breathing tube. And so then if that's the case, the following follow-up around that is to make sure that they have documents in place to protect themselves from the system. And because the default in the system may or may not align with their goals. Part of that is going to make sure that they have a medical power of attorney in place. And then this is someone who knows the patient, knows their values, who will speak on behalf of the patient if they were so sick they couldn't speak for themselves.
Uh,
These are things that can get very complicated if paperwork's not in place. It can make what is a tough situation for families who are not sick. It can make it all the more difficult for them and dramatic.
so, based upon your important work in this area, um, and again, recognizing that we're speaking in generalities in lots of this, how would you describe your impression, your experience with the current state of affairs of advanced care planning as it intersects with Black aging? And are there concerns or hope in terms of the long term implications of that state of affairs?
Yeah, I think that kind of again to generalize, the Black community has a historic and valid mistrust of the healthcare system, and that continues to this present day. That continues in folks up and down kind of the generational line from young kids to those who are more senior. And I think that as a result of that, having conversations around interventions that people may or may not want, having conversations around interventions that the medical team is recommending to stop, and that may lead to death. I think that there then is a tension point in the community where the community says, I don't know if the healthcare system is just trying to get me out the door. I don't know if the healthcare
Yeah,
system is just going to push me away to die. And I don't know if the healthcare system is being open and honest with regards to what other treatment options might be available. And that really can flare up in these conversations, which is all the more reason, I think, to have them and wrestle through the tension, struggle through the tension to get out the other end, all the board, all the better.
yeah. And so one of the things that I have found really intriguing in our conversations is this role, this important role, and in some ways, at least in terms of people's lay understanding, may be a reframing of palliative care and the role that that can play in this space, whether it's advanced care planning or life milestones more broadly. Can you share that?
Absolutely. I think, I've had patients oftentimes palliative care in any community is associated with hospice. And so folks, if palliative care comes to see them in the hospital, they immediately think, oh, that this is the death panels. These are the death doctors. They're gonna force us into hospice. And that, while that sometimes is the case based on the patient's values that we're hearing, there are many times, many times, where in my role in palliative care and with working with my team, the patients, based on their values, have made it very clear that they want all the life-sustaining therapies offered them. Doesn't matter that they have widespread cancer. Doesn't matter that there's not treatment options for that cancer. And then my role is to help advocate for the medical teams to give them all of these treatment options, and not, I guess, lift the patient's voice to the top in that way, even if it goes against what the medical providers are recommending. Really trying to make it purely patient-centered.
So in this whole kind of reframing of palliative care, this real stressing of the important conversations around advanced care planning and the
Mm-hmm.
value that they bring not only to people but their families in what can be really difficult moments.
Mm-hmm.
Who are the key stakeholders in advancing this movement, if you will, this rethinking of this whole context of life and aging? Who do you see as key stakeholders, and how do you think we mobilize them?
Well, I think some of the primary key stakeholders that need to be there from the beginning are folks in the community and leaders in the community, and kind of exploring kind of in each community what are the leadership systems. The Black church, for example, I think could be a great stakeholder in this, and having conversations within the church and having conversations amongst the pastors to help them reframe for their congregation end of life things. I think, barbershops and beauty shops are also a place of communal locations, and there's leadership there. So those would have to be some of the primary stakeholders, in my opinion, to have a seat at the table and drive the conversation. I think you also had to have palliative care providers or hospice providers at the table to lift up kind of medically how to help, I guess, is help with the interface between the community and the medical providers, because I do think palliative care does it better than other specialties, and so I would want them there at the table. And then I think that if we're going very granular, then who would be at the table would it be purely up to the patient? I think that some people want their spouses at the table or their significant others, other people don't. Some people want their children there, other people don't. And then what I try to do, I guess, in my role, not pivoting, but going a little off track, is that I will take the onus on, once I hear from the patient who they want there, who they don't want there, then I can be the bad guy, so to speak, so that the patient isn't having to make those decisions or make those calls.
So, as someone who has spent the last number of years focused on this notion of mobilizing urban communities,
Mhm.
I want to share with you uh, just that it does my heart good for you to not only lift up the church, but barbershops and hairstylists and others, uh, because so very often these very critical, trusted voices are overlooked
Mhm.
when we think of leadership in mobilizing people in the community.
Mhm.
So, one of the things that we talk about in Aging While Black are policy driven responses and people driven responses.
Mhm.
Uh, and so when we think about palliative care and the reframing, when we think about advanced care planning, are there either or both that come to mind for you, things that are more policy focused and others that are more communal or people driven?
So I think people driven and for palliative care and hospice where we are now would be a lot by word of mouth, and doing conversations like this to try to help differentiate what palliative care is from hospice. I think that then once people have had their own lived experience in both of those, either as a patient or as a family member, that can provide good testimony for those around you. And word can spread like wildfire. Right now, engaging with palliative care in the hospital really is a happy accident. And but it's one that the whole focus again is on your improved quality of life. I'm not trying to talk you in or out of things, and so
Yeah.
it's kind of automatically an added value, in my opinion. So to have some testimonies from those who have participated, with regards to kind of policies and systems, I think that there is a national conversation amongst leadership at Center for Medicaid and Medicare around how to better incorporate a repayment structure for palliative care. Because if palliative care was able to have be more reimbursable, excuse me, by Medicaid and Medicare, then you may find that there's an automatic palliative care consult the minute you get in the hospital, the minute you're diagnosed with serious illness, whether you like one or not, because the system has decided that this would be beneficial for you too. And that could also be a way to get more people in the fold and more people accessing the services.
To tweak your comment just a
Mhm.
bit, because I think it is a very important one, that the system has determined that this service is a benefit to you,
Mhm.
and the system has determined that this service is an important part of the system.
Mhm.
That
That's
how we think about the response to serious illness
mhm.
is that palliative care is a critical element of that, and how
Absolutely.
we create better outcomes for people and their families.
Absolutely. And you know, before the advent of some of these high-tech surgeries and antibiotics, and before the advent of kind of high-tech chemotherapies, all of which have happened really in the last 60 or 70 years, most of medicine was palliative care. People showed up at the hospital with a heart attack and they received medicine so that their symptoms were controlled, and then a tincture of time to see how the body does, and the body would either survive or not survive. That the same thing could have been true for pneumonia, you know, and in managing the shortness of breath, managing the weakness. And so I lift that up because I do think that at the somewhere in the core, and we medicine may have forgotten it, but somewhere in the core, palliative medicine is at the heart.
Well, certainly on both of those ends, the people driven part of understanding the importance of uh, testimony and valuing people's lived experience and elevating people's lived experience as they go through this with family members and others, as being an important element of the stories that we tell in uh, community largely, but Black communities especially.
Mhm.
And on the other end of that, being a part of the aggressive advocacy efforts with CMS
Mhm.
on reimbursement protocols and practices as it relates to palliative care.
Mhm.
Uh, Certainly would offer the Aging While Black platform as a partner in both of those very
Absolutely.
important strategies. So I start these conversations in the same way each time, and I end them in the same way. And it is by recalling that Aging While Black seeks to be a catalyst for movement building.
Mhm.
And movement building around these pillars of recalibrating the village,
Mhm.
embracing innovation and rapid change, and
Mhm.
leaning into Sankofa.
Mhm.
You and I have talked about this effort over the last few months.
Mhm.
At this point, what would be your best hope for this movement?
Um, I think that what would be my best hope for, you're talking about for the Aging While Black movement.
Yes.
I think that they're through this. there would be almost like the mission, it would be success of the mission and vision. I think what you seek, where it's a kind of interdisciplinary network of professionals all across the country, and not just professionals. Again, I think that having folks, community members who are not professional are stakeholders too, and so to be able to have a extended network of people across this country for which the community could say, I don't know what I need, but this is going to be where I start. And Aging While Black is so rich and so connected that it's almost like, well, I don't know, but I'm going to call Raymond right now and he'll be able to help you out, or vice versa. And that is where I think that's what the hope, and it seems to be where we're headed. I think we have a long way to go.
Indeed, we do. But the old adage about the journey of 1,000 miles beginning with one step,
Absolutely.
the first step. I'd like to thank you for taking that important step by being such a willing participant, contributor, uh, explorer in this space with us, and availing and inviting your network to share the journey with us. And I am eternally grateful for that.
So
Uh,
absolutely happy to help however I can.
and as I am thankful for your time today. And so, Dr. Maurice Scott, Scotty, thank you so much for making time for this conversation. And thank you for your partnership in building the movement.
Absolutely. And if I can just leave you with one more pearl around palliative care and advanced care planning discussions and documentation, if you were to imagine that the minute you get sick, you're starting a cruise, and you're going on a cruise, you want to have lifeboats. You don't want to use them, but you want to know that they're there. And all of the conversations we have are the lifeboat conversations. And we're right there with you, hoping you never need them. But if you do, you already
You
have.
want them to, you want them to be there.
That's right.
Thank you for that framing. It is very helpful. Dear friend, thank you so much for your time. Thank you for
Absolutely.
joining us with Lunch with AWB.
Absolutely. Look forward to seeing you all soon.
Thank you. Share, like, distribute with your networks, everyone. And thank you so much for taking the time to share with us.